Mabel Jung, and you're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. I'm back now with Chad Gray, who is the CEO of Integrated Mechanical Care, which is responsible with coming up with innovative programs for accountable care organizations and community care organizations. Welcome to you, Chad.
Thank you. Pleasure to be here.
Now, what are some of the programs that you've developed? What do those look like?
So, we've got three distinct business units, if you will, that are part of the organization. We have training and educational programs for providers around the assessment and treatment selection for musculoskeletal patients. We've got a data and analytics division of the organization that measures the impact that we have on patient-reported outcomes at the clinical level and on claims cost at the payer level. And so we use the data that spins off the clinical experience that the patient reports to us with, combined with the claims data that comes out of the economic impact that we have in managing these people with a different kind of model of care. And we use those data points to kind of drive continuous improvement at the clinical level for the providers that we've got in our network. And then of course we've got a population health program or community based care program that has us embedding clinicians into practices that exist in Cert communities, or developing or designing a new clinic in an area where there may be a demand or a population of people that need to be served, or they don't have access to the kind of services we deliver. So those are the three kind of areas that we focus in on: data analytics, population health, and community-based care, and then training and education for providers that don't have competency or need a better skill set kind of in this area of assessing, examining, and treating musculoskeletal disorders.
Right. Are your programs scalable across different states and different communities?
They are. Currently we're located in 7 or 8 different states in the U.S. We've built out infrastructure and operations that allow us to scale up and kind of move into an area relatively quickly and deliver the programs that we just discussed. And so yes, the organization is built around a scalable solution that has sustainability in regards to the results and the outcomes produced in the program.
And what's the system behind it that makes it fairly easy to get this going in another place other than where you're based, which is in Tallahassee?
The system meaning?
Meaning sort of the programs that you've established within those 3 areas that you talked about
What
earlier.
makes it easy to introduce them? The relationships that we have with self-insured employers certainly help drive a lot of the introduction into certain communities. They've got a well-defined population of folks that have a challenge around managing musculoskeletal conditions, and of course the payer has a significant issue in regards to the cost typically associated with that. So large self-insured employers help us drive into certain regions or areas and deliver care to the populations they have in their plan. Health systems are starting to become helpful at kind of driving access to these types of programs as well, because of some of the mandates that are coming from the federal government and CMS specifically around cost and quality. And so they've taken recognition of some of the efficiencies and some of the effectiveness and value that we drive at the musculoskeletal level, and so they're engaging with us at a very high level as well to introduce these programs across communities in this country. And
what about paying for those services? Is it different than what we might see in some other organizations?
To some degree. We may partner and have some traditional fee-for-service relationships with employers or payers, but that's not typical. Typically we have a case rate or kind of a global fee or payment that we receive for the care management process around the life in that plan or with that employer. And of course the movement for us is towards full capitation at some point, where we assume all the risk for that life or for all the lives inside that defined population or in that plan.
How would people, why would people want to come to Integrated Mechanical Care, do you think? If you're trying to pitch a new client, what is the driver behind a company picking you over somebody else?
We've validated the program results over the last 25 years with patient-reported data, and that's been a missing element in healthcare for a number of years in the MSD space, or the musculoskeletal space. There is tremendous variability that exists in the system as it pertains to how we examine these conditions and the care that is then selected for these conditions. And that has a very high cost profile for not only the employer or the payer, but the patient as well. And in this particular space, the outcomes that have been associated with the traditional community-based care models that have been out there for a number of years in play aren't that great. So we see a very high incidence and a very high prevalence rate in these populations. These people are suffering from a condition that classically produces pain and disability. So they lose function, they lose the ability to go to work, to be productive, to recreate, to have quality of life time with family. And so this is a space or an area of healthcare that really does drive the consumers towards a solution if they can find it. So we go into an employer and kind of predict what their profile of their population looks like, because it is pretty consistent across the land, and we help them target communications and engagement towards plan members that talk about the success of the program, the outcomes associated with it, how it's different than traditional care models that you see in most communities, and that drives steerage into the program. And then the results ultimately speak for themselves. Patients get better quicker, and they go back to friends, family, co-workers, and tell them about the experience. That drives people into the clinic at a very high rate as well. And then, of course, at the end of the year, when we look at the costs associated with managing this population with our model, the payers are quite happy as well, because the costs typically drop by as much as 25% for the lives that we're touching. So it's a significant shift in cost for the payer and for the patient, and it's a significant improvement in the overall health outcome of these people that are being managed in traditional care models that don't have a lot of validation associated with them and a lot of efficacy associated with the treatment methods that are being chosen or selected for them.
Okay. Chad Gray, thank you so much for dropping by.
My
Appreciate
pleasure.
it.
Yeah, take care.
And I'm Mabel Jong. Thanks for watching. Stay tuned.